Good morning, everyone. It's my great pleasure to take part in this meeting. I'd like to sincerely thank the organizing committee and the developers of Kawarabi for this chance. I was asked to talk about Kawasaki disease experience at my institution, Makassed Hospital. So as we know, Kawasaki disease is one of the most common forms of systemic vasculitis in children, and that's the case in my institution. Kawasaki disease is regarded as a vasculitis of unknown cause and a self-limited disease with fever and other manifestations of acute inflammation that usually can last up to an average of 12 days if untreated. However, without timely management, we know that up to 25% of patients can develop coronary artery aneurysms. That's why initial management of patients with KD is focused on early diagnosis and treatment with IVIG. So as I'm talking about the experience of my institution, which is regarded one with limited resources, we know that management in these settings is very important because this carries high risk of severe complications because of the delay in the management and diagnosis. In these settings, usually there is limited access to advanced diagnostics, although Kawasaki disease is a disease that relies on clinical criteria, but still echo is important and sometimes more advanced imaging are needed. There is limited access to healthcare facilities or specialties, again, delaying the diagnosis and timely management. There are challenges in the access to standard treatment, of which IVIG is considered a foundational treatment, but unfortunately it is costly, not always available. However, on cost-benefit analysis, it is found to be one of the most cost-effective managements. There's also an economic burdens on families and health systems, so all raising the need for awareness among healthcare providers. So regarding my institution, Makassed Hospital, it is located in Jerusalem in the Mount of Olives. There the blue arrow shows where it is located. It is founded in and the image below. It was founded in 1968, and initially it had 60 beds that expanded over the years to 250 beds. It is considered the main tertiary Palestinian hospital serving the Palestinian community of Jerusalem, West Bank, and Gaza Strip. But sadly, since the onset of war in Gaza, no Gazan patients are allowed to exit the Strip. And also the hospital serves as a training hospital in association with Al-Quds University, and it endorsed the first Palestinian residency program. So the KD management started in my hospital in the early 1990s. In 1992, the first pediatric echo was available, and IVIG was made available in the late 90s. Prior to that, IVIG wasn't widely used, but usually the patients used to pay for it. We usually see 5 to 10 cases per year, and as expected, they come in clusters. Over the years, we saw a trend or an increase in the number of cases, probably due to the increased awareness back home. Pediatricians always think or consider Kawasaki disease in patients presenting with fever of lasting more than 5 days if there is no other explanation. So as for the symptom presentation, as expected, most patients are referred with persistent fever. As we are a referral center, most of the cases that we see are either incomplete KDs or refractory KDs. We have also a few patients having atypical presentation, and usually they are the ones below the age of 1 year. I also have to mention that some of the cases are misdiagnosed as Kawasaki, but in fact they have other rheumatic diseases such as systemic JIA, autoinflammatory diseases like hyper IgD, FMF, in addition to other vasculitis like PAN. I have to skip some slides because of the time. So this is a case that presented this year to my hospital for a patient who initially was managed in another hospital. She was 3 months of age. She had prolonged fever with very high inflammatory markers and medium to small size aneurysms on echo. She was treated with 2 doses of IVIG and steroids before 10 days of onset of the fever. But sadly, she persisted to have the fevers and the high inflammatory markers. And at the time she presented to our hospital, she had gangrene in the toes. So this patient was treated with iloprost, steroids, in addition to infliximab and anticoagulation. And luckily, she is doing well. I had to mention that other diagnoses were considered as well, including MIS-C and polyarteritis nodosa, other autoinflammatory disorders like DADA2, but we cannot rule out the possibility of refractory KD. In terms of diagnosis, we used the known guidelines for the incomplete Kawasaki. We look for the high inflammatory markers. We do echo. We look at the supplemental lab criteria and treat accordingly. I was actually the first pediatric rheumatologist in Palestine, and after completing my fellowship, some of the diagnostic misconceptions that were addressed, pediatricians used to think that in cases of incomplete or atypical Kawasaki, a normal echo does exclude the diagnosis. They used to think that the presence of infection does exclude Kawasaki. However, there are studies that have shown that up to 1/3 of patients with KD can have concurrent identifiable infections. Also, some patients with mild coronary dilatation and fever were treated as KD, but in fact, they were found to have other rheumatic conditions, mainly systemic GIA and autoinflammatory disorders. Okay, so for the diagnostic challenges, we face the same ones that are encountered in limited resource countries, but adding to that, because our hospitalized in Jerusalem patients have the difficulties in transportation. Some patients are denied permission, or permission can take some time to be able to enter Jerusalem, and all of that can affect their management because there is always somehow a delay in the diagnosis and management. As for our protocols, they are somehow they are similar to the known guidelines. So we give a high dose of IVIG 2 grams per kg. Previously, we used to use aspirin in a dose range from 50 to 80 milligram per kg per day, depending whether there is hypoalbuminemia or elevated liver enzymes. But now we are more using the antiplatelet dose from the beginning, as studies haven't shown really difference in the coronary outcomes, and to avoid the aspirin possible side effects. So in also the change was that we started giving steroids earlier, especially in severe cases like in KD shock, or in patients at high risk, and those having abnormal echo on presentation. Now, those who do not respond to the first dose of IVIG, after 48 hours, we give a second dose. And then if they do not respond, if steroids wasn't given, we give infliximab 5 to 10 milligram per kg. But luckily, we haven't needed it that much. And those who do not respond to infliximab, we try with anakinra. As for the availability of medications, IVIG is available at our hospital, but this honestly depends on the economical status. Sometimes we ran out of it, but the good thing that any patient who requires IVIG will get it at the end. We have the low molecular weight heparin, warfarin, but oral anticoagulants are not available. As for the biologics, the infliximab is only made upon request, as well as for the anakinra for the severe cases. But patients who require anakinra after discharge from the hospital, they will have to pay for it because the Ministry of Health unfortunately doesn't cover it. So we see the usual side effects that are expected, especially the fevers, the chills, and sometimes hypotension. And we reduce the rate of the infusion and give antihistamines. For the headaches, we try to give good hydration. Aseptic meningitis is also common. We see hemolytic anemias, but it rarely requires blood transfusion. And also allergic reactions can be seen with the IVIG. So again, we reduce the rate of the infusion. Some of the complications that we see: KD shock, a few cases of macrophage activation syndrome, some cardiac complications, and hemolytic anemia. As for the outcomes and follow-up, patients are followed or monitored for the fever. We keep an eye on the post-hemolysis blood work for the possibility of hemolysis. They have regular cardiac evaluations depending on the echo findings. As for the immunizations, we advocate for the use of influenza vaccines in those using aspirin chronically, and we ask the patients to hold on giving the live vaccines from 6 to 11 months after IVIG, and we encourage holding the aspirin during the infections because of the risk of Reye syndrome. So again, the challenges in management: lack of some medications, the high cost of medications, and access to follow-up care. Finally, as we're talking about Kawasaki disease, our aims of management and treatment are to prevent the cardiac complications. So a way to do it is to invest in training and awareness, and to strengthen regional healthcare networks, as we're doing well in Kawarabi, and improve data collection and surveillance. Thank you very much.